Good afternoon, everyone. Thank you for the opportunity to speak about Cefiderocol, a newer antibiotic that has emerged as an important and valuable treatment option for patients with difficult-to-treat gram-negative infections. And I'll be focusing on the use of Cefiderocol in patients with bone and joint infections. What I'm going to cover includes mechanism of action. Cefiderocol is a fascinating antibiotic with a unique mechanism of action. What are its clinical indications? I'll show you clinical trial evidence that reporting on the clinical efficacy of Cefiderocol that form the evidence base for the FDA approval. I'll draw your attention to a few case reports and case series describing patients with bone and joint infections successfully treated with Cefiderocol. What are the pharmacokinetics and what host factors, what drug-drug interactions do you need to take into consideration when prescribing Cefiderocol? And lastly, why is it so expensive? And what have been done to make Cefiderocol more accessible and affordable? Cefiderocol is what we call a cefiderocol and cephalosporin. Cefiderocols are molecules produced by gram-negative bacteria and are important in bringing in iron through the outer membrane of gram-negative bacteria for their survival and growth. What Cefiderocol does is it sneaks in through those ion channels in outer membrane. It gets in very efficiently without being destroyed by beta-lactamase. Once Cefiderocol gets inside the periplasmic space, it dissociates from the iron and binds to penicillin binding protein, primarily PBP3, to inhibit peptidoglycan synthesis, causing bacterial cell death. This is the chemical structure of the molecule. Cefiderocol contains a cephalosporin core with two side chains. Its chemical structure is similar to ceftazidime and cefepime, which makes Cefiderocol stable against hydrolysis by beta-lactamase. The unique chemical component is the catechol moiety on the C3 side chain, which chelates iron and mimics naturally occurring cefiderocol. After chelating iron, Cefiderocol is actively transported into the bacteria by its iron uptake system. So that's how Cefiderocol works. I always think of them as like the Trojan horse. It sneaks in, the bacteria think it's bringing in iron, but in fact, it's bringing in this cephalosporin to do bad things. We know that the most common mechanism of beta-lactam resistance among gram-negative bacteria are purine changes, so antibiotics can't get in, upregulation of efflux pump to get rid of antibiotics, and beta-lactamase production to destroy beta-lactam antibiotics. Cefiderocol was designed to overcome challenges presented by carbapenem resistance mechanisms. By using Cefiderocol-mediated entry into the cell, Cefiderocol has the ability to overcome these common mechanisms of resistance, making it a good alternative for patients with difficult-to-treat gram-negative infection that are resistant to carbapenem. Cefiderocol is a drug indicated for the treatment of infections caused by gram-negative bacteria in adults with limited treatment options. It has broad in vitro activity against gram-negative bacteria, including multi-drug resistant bacteria, such as carbapenem-resistant Enterobacterales, carbapenem-resistant Pseudomonas aeruginosa, and Acinetobacter baumannii. Cefiderocol has little or no activity against gram-positive bacteria or anaerobic bacteria due to their inherent resistance. In 2019, Cefiderocol received FDA approval for treatment of patients with complicated urinary tract infection, including pyelonephritis, and hospital-acquired bacterial pneumonia, including ventilator-associated pneumonia caused by gram-negative bacteria that are resistant to other antibiotics. In 2020, the European Union approved Cefiderocol for the treatment of infection due to gram-negative bacteria in patients with limited treatment options as well. But outside of North America and Europe, access to this drug in low and middle income countries have been very limited. Cefiderocol was added to the WHO Essential Medicine list and targets a number of gram-negative WHO priority pathogens. The AWARE classification groups antibiotics into 3 simple categories. Access antibiotics have narrow spectrum of activity, low cost, a good safety profile, and low risk of selecting out resistance. Watch antibiotics have broader spectrum and are recommended for patients with more severe clinical presentation. Cefiderocol falls under the reserve group antibiotics, which includes antibiotics that should be reserved for treatment of infection due to multi-drug resistant bacteria. According to the AWARE classification, antibiotics in the reserve group should be treated as the last resort option. These antibiotics should be accessible and their use should be tailored to highly specific patients and settings when all alternatives have failed or are not suitable. The approval of Cefiderocol for use in complicated UTI and nosocomial pneumonia was based on 2 large randomized controlled trials that showed non-inferiority to comparators. In the first trial, 450 patients with complicated UTI were randomized to Cefiderocol or imipenem. In the second trial, 300 patients with hospital-acquired pneumonia, including ventilator-associated pneumonia, were randomized to Cefiderocol and high-dose meropenem. In both trials, the proportion of patients with clinical cure was similar in both groups. These trials also highlighted improved side effect profile of Cefiderocol relative to older generation antibiotics for multi-drug resistant gram-negative bacteria such as colistin, especially regarding nephrotoxicity. Cefiderocol was safe and well tolerated. The most common adverse events reported across the trials were diarrhea, infusion site pain, headache, and nausea. Elevated liver function tests and hypokalemia have been reported and should be monitored in patients on Cefiderocol. There were no reported laboratory abnormalities to suggest that Cefiderocol interfered with iron homeostasis. The third trial differed from the previous 2 studies in that it was pathogen-directed. It enrolled patients with serious carbapenem-resistant gram-negative infections. 19% of those were Pseudomonas aeruginosa, and randomized to Cefiderocol or best available therapy. Unfortunately, patients with bone and joint infections were excluded from this trial. The study showed similar efficacy between the groups, but a concerning finding of higher rate of all-cause mortality in patients with pneumonia and bacteremia who were treated with Cefiderocol, particularly in the patient subset with infections due to Acinetobacter baumannii. One hypothesis for this was possible undetected Cefiderocol heteroresistance. Heteroresistance is when a bacterial isolate has a minor resistant subpopulation that coexists with a majority susceptible subpopulation. And when an antibiotic is given, the resistant population is selected for and predominates, which can lead to treatment failure. This was the first case report of the successful off-label use of Cefiderocol as compassionate treatment in bone and joint infection. A 15-year-old Nigerian man suffered a femur fracture and underwent intramedullary pin placement. This was followed by recurrent wound infection, despite surgical debridement and receiving a variety of antibiotics. About 10 months after the initial incident, there was again wound dehiscence and imaging showed signs of chronic osteomyelitis. Post-debridement on tissue culture, it grew an extensively drug-resistant Pseudomonas aeruginosa and an ESBL-producing Klebsiella pneumoniae. Due to the lack of treatment options and the risk of amputation if there were further progression of the infection, the clinicians made a request to Shionogi, the pharmaceutical company, to provide Cefiderocol for compassionate use. After 10 weeks of Cefiderocol monotherapy, the patient was taken back to theater for a bone graft and antibiotic nail exchange. The patient completed 4 additional weeks of Cefiderocol for a total of 14 weeks with complete cure and had returned to playing soccer. Between 2020 and 2024, there were at least 5 case reports describing real-world experience of patients with bone and joint infections successfully treated with Cefiderocol. These included a 29-year-old man with fracture-related polymicrobial wound infection and osteomyelitis of tibia. Cefiderocol was started after removal of all foreign material and was continued for 2 weeks and in combination with colistin. In another case report, a 57-year-old man developed a polymicrobial osteomyelitis that grew XDR Acinetobacter baumannii. This patient was successfully treated with surgical debridement and Cefiderocol when no alternative antibiotics existed. Cefiderocol was well tolerated in these case reports. The only notable safety concern with prolonged use of Cefiderocol was possible hematological toxicity with a drop in neutrophil count, but it resolved without dose adjustment. This was a retrospective observational study recently presented at ESCMID, reporting treatment outcome of patients in the Cefiderocol Access program in Spain. Of 260 patients with gram-negative bacterial infection, over 60% were critically ill. Patients received Cefiderocol for up to 28 days, and the median treatment duration was 10 days. Overall, clinical success rate in patients who received Cefiderocol was 84%, and the 28-day mortality rate was 21%. As highlighted in the red circle here, 6 patients had bone and joint infections, and all 6 patients were successfully treated with Cefiderocol. In this study, a patient with pyoderma gangrenosum, osteomyelitis, and bacteremia with an extensively drug-resistant Pseudomonas aeruginosa was successfully treated with Cefiderocol. The investigators obtained bone and subcutaneous tissue while the patient was on Cefiderocol and measured Cefiderocol concentrations. Cefiderocol was dosed at 2 grams every 8 hours, given as an infusion over 3 hours. As it's shown here, the amount of Cefiderocol in bone and tissue at steady state suggests adequate penetration in bone and soft tissue. Of note, tissue and bone samples were not suspected to be directly infected, so this is not an estimate of the amount of Cefiderocol in infected bone. But acutely infected bone is believed to have a higher degree of blood perfusion and potentially even higher drug concentration. The mechanism of uptake of Cefiderocol by the bacterial ion transport system may play a role in Cefiderocol's efficacy against biofilm-associated infections. Iron is crucial for biofilm formation, and sideropol production is upregulated in biofilms. In the picture on the left, bacteria secrete sideropol to compete against lactoferrin and transferrin for free iron. In the picture on the right, Pseudomonas biofilm increase pyruverdin production, which is an important sideropol, and stores excess iron in the biofilm. When bacterial iron acquisition systems are upregulated, both uptake and in vitro activity of Cefiderocol increases. So therefore, Cefiderocol may be particularly useful against biofilm-forming bacteria by capitalizing on their enhanced iron uptake. Recommended Cefiderocol dosing for patients with normal renal function is 2 grams given intravenously by an infusion over 3 hours every 8 hours. Because it's a cephalosporin, the activity of Cefiderocol is best described by time-dependent killing, which is enhanced by giving it as an infusion. Cefiderocol is primarily renally excreted, and dose reduction is required for renal impairment. Cefiderocol does not undergo significant hepatic metabolism, and dose adjustment is not required for hepatic impairment. Currently, there are no recommendations for weight-based dosing in obesity. The risk of Cefiderocol being either a perpetrator or victim of drug-drug interactions appears to be low. Getting Cefiderocol to patients who need it requires overcoming a significant number of technical, regulatory, and economic challenges. The price range for Cefiderocol is astronomical. A 6-week course of treatment, generally suggested for chronic osteomyelitis or prosthetic joint infection, cost 1.3 million rand. Cefiderocol was developed by Shionogi, a Japanese pharmaceutical company, and it has been exclusively manufactured by this company. The high cost of Cefiderocol may be related to the lack of competition between manufacturers, the lack of generic producers, and the high cost facilitating importation and approval by local health regulatory authorities. But the good news is that in 2022, Shionogi and GARD-P announced a groundbreaking license and collaboration agreement. The Global Antibiotic Research and Development Partnership, also known as GARD-P, is a Swiss nonprofit organization created by the WHO to ensure that everyone who needs antibiotics receives effective and affordable treatment, no matter where they live. This agreement includes a technology transfer agreement that aims to significantly transform the landscape of access to Cefiderocol for countries around the world. This is the first license agreement of an antibiotics to treat serious bacterial infection between a pharmaceutical company and an NGO that's driven by public health priorities. Under this agreement, GARD-P will manufacture and commercialize Cefiderocol in 135 countries that include all low-income countries, most middle-income countries, and select high-income countries. Here are a few take-home messages. Cefiderocol acts like the Trojan horse, and it enters bacterial cells through ion channels. It comes with high costs, and access to this drug in low and middle-income countries is currently very limited. However, recent collaboration agreement between Shionogi and GARD-P highlights the issue of ensuring access and affordability globally to bring this life-saving drug to resource-limited settings. Cefiderocol has an important place in the clinician's armamentarium against multi-drug resistant gram-negative infection, where there are currently very limited or no treatment options. But even if we could expand access to this new antibiotic, making sure that Cefiderocol is appropriately and responsibly used through antibiotic stewardship is a key intervention necessary to mitigate the emergence of resistance to Cefiderocol. And lastly, more observational data from real-world setting will allow for refinement of Cefiderocol's place in therapy and hopefully broadening its indication to include bone and joint infections. Thank you for your attention.